Kristen? Can you hear us, Kristen?
She's muted.
Here.
Okay,
Sorry.
thank you, Rich.
Here.
And I am here, so we have full attendance by the board. So if we'll pause for a moment and ask people to join me in the Pledge of Allegiance. I see our flag before us. So here we go. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay. Thank you, everyone. That takes us to item number 3 on the agenda for today, which is the public comment period. If you are a member of the public or staff and you'd like to make a comment, now's your time to do so. I think you have to raise your hand in the reactions button at the bottom of the Zoom screen to indicate that you'd like to make a comment. So I'll delay for a minute to give you an opportunity to raise your hands and for TK to link you in.
And for those that are joining via telephone, you can press *6 to unmute yourself and to address the board.
Ken, it looks like a couple of folks perhaps aren't completely joined on, so I wonder if maybe we might want to give another opportunity later.
Okay, you mean they haven't signed in yet, or?
Oh, I just mean, I'm just looking at the participant list and there's a couple of folks that still says connecting to audio. So I'm just wondering if maybe if they possibly had anything they wanted to say, if perhaps we ought to give them another opportunity.
Like one more is trying to connect. Looks like Kelly is trying to connect. So
Alternatively, Jerry, maybe we should just sit here for a minute and see, and I can restate it.
Okay.
So folks, if you're just joining us, we are at the Seneca board meeting. We are at item number 3 on our agenda, which is the public comment period. So if you've just joined and you were unaware that this is the time to make public comment, you're welcome to do so now. TK, I'm assuming no one's raised their hand.
That is correct.
Okay. That said, then I will move on. We have a item on the agenda here, a request to amend the agenda. This is to add item number 10 to the end of the action item list. This is in relation to the Seneca Healthcare District rebranding of the logo. So we'll need a motion to add that to the agenda from a board member.
I'll move to change the agenda.
Dr.
A second.
Walls? And that was Jerry's second, right?
Yeah, correct.
Okay. Kristen, how do you vote?
Aye.
And Rich?
Aye.
Okay. And Jerry?
Aye.
And Dr. Walls?
Aye.
And I will vote aye as well. So we will add that and move that to number 10 on the agenda. And next up is the board meetings, agenda meetings from January 28th. I'm hoping you've all had an opportunity to look at those and wondering if there's any changes.
Ken, I would like to make a comment.
Please.
On the previous minutes, and I've already discussed this with Renee, but I think it should be noted, there was issue of abbreviations and quality assurance and peer review was supposed to be brought to the next regular board meeting, which is today's, and it isn't on the agenda for today.
Okay. And as such, we want to make sure that that is carried over until to our March meeting. Am I correct there, Dr. Walls?
That's correct, because there was some work that TK had to do and it's not completed yet.
Okay, very good. The other piece that's similar to that, if you look at item number 15 on our January minutes, it says appointing members to serve on the Strategic Planning Committee, and I don't show that on the agenda either. So can we please, I don't know if that needs to be an action item or if that's something that we just as a board can discuss and appoint.
And if I can, just, I think if we push that to the next board meeting, I think we'll be more prepared to ask to speak to that as well. So
Okay.
planning update will provide some information.
Okay, thank you for that. Okay, so what I need is a motion to approve the board minutes from January 28th, noting that there are some things the things Dr. Walls mentioned, and the Strategic Planning Committee appointments need to be added to the next meeting.
I'll make the motion.
Hey, Jerry,
I'll second.
Kristen seconds. Dr. Walls?
Aye.
Okay. Rich?
Aye.
Okay, and Kristen?
Aye.
And Jerry?
Aye.
And I'll vote aye. Okay, very good. Moving on, item number 6, the medical staff report. Dr. Cooper submitted the following items. These items were approved at the February 9th meeting of the med staff and now require board approval. So these are initial appointments for telepsychiatrists, 3 of them, in fact, Michael Zoglio, Walter Singer, and Darcy Trankel. We also have on here a reappointment of Megan Fenvo and a miscellaneous piece here. There's the delineation of privileges from form signed by Chief of Staff, credential chair, and ready for President of Seneca Board for signature. This relates to Dr. Cecil Matrip, also a psychiatrist.
And I'll make the motion to approve the initial and reappointments.
Okay. Second, please.
I'll second that.
Okay, Kristen, your vote.
Aye.
Rich?
Aye.
Okay, Dr. Walls
Aye.
and Jerry,
Aye.
and I will vote aye as well. So the motion carries. All right. Item number 7 takes us to policies and procedures. We're being asked to approve the following procedures, and these were approved again by the med staff on February 9th. This has to do with LAC 039001, NSG 062001, and we have one. I think we should take the rescind separately. So we're approving items number 1 and 2 under policies and procedures on our agenda. Can I have a motion for that?
So moved.
Was that
I'll
you, Dr.
second.
Walls?
Yes, that's Dr. Walls. So moved.
Okay, and Jerry?
I second.
Second. Kristen?
Aye.
Okay, Rich?
Aye.
Okay, and Jerry?
Aye.
Dr. Walls?
Aye.
And I will vote aye. So the first 2 there carry. We also have an item here that is to be rescinded. And this is a prescription refills policy, LAC PRO-012.002. So any questions? If not, I will accept a motion to rescind that policy, that procedure.
So moved.
Okay,
I'll second.
second, okay.
I'm curious, what did we rescind? What was the aspect of the policy that,
What we rescinded was the old prescription policy, and we approved the new one.
I know that, but what's the difference?
I think it's just the way it's formatted.
And I also noticed that when it came to a patient calling in with an acute problem, the old policy said that a nurse would make the decision about whether to do a med refill, or I'm sorry, prescription, and the new one says it'll be the provider. That's the difference. That's the difference that I.
That's the only difference you saw, Jerry?
That's the only difference that I saw. They're pretty short.
Okay, thank you.
This is Anne. I can speak to the changeover. About a year ago, maybe a year and a half ago, we had made the decision that all procedures had to live under a policy statement. So this is an updated procedure, but now it's living under a policy statement. So we're getting rid of the procedure, put it under a policy to make it more formal, and more in line with what state wants to see when they come through, when they do their surveys.
So Ann, if I'm correct, everything will be titled policy and procedure going forward?
Correct.
Okay. Okay. Additional questions? Okay, we did have then a motion by Jerry and a second by Kristen. Dr. Walls, how do you vote?
Aye.
Okay, Rich?
Aye.
Okay. Kristen?
Aye.
Jerry?
Aye.
And I'll vote aye, so that policy is rescinded, procedure is rescinded. And that moves us into the January 21 financial report. So I'm assuming Steve is with us to speak to that.
Yep. Hello, everyone.
Hello.
Okay.
Hey, Steve.
Okay. In tab D of your packet, we're looking at the month of January 2021, 7th month of our fiscal year. We did have experience a little bit of bounce back from December, which was, again, our first full month of where we had COVID present in our facility, both with the residents and patients and staff. So the revenue came back nicely. We still were under budget total, $145,000, and the bulk of it, more than the bulk, 194 of it was outpatient, and we did have a slight positive variance on the inpatient side for the net 145. When we take out the adjustments to revenue, which were positive from a dollar perspective and just slightly positive from a percentage perspective, we had a negative variance of $78,000. Our operating expenses for the month in total were negative $42,000. Obviously, the thing that jumps out at us is the salaries and wages. In the month of January, we lost or reduced the use of contract labor. As you can see, the contract labor, which is essentially registry nursing for the nursing home and on the acute ED side, that we had a positive variance about 400, that'd be nice, of $44,000. Salaries and wages were negative 88. In order to keep the floor staffed, both from losing the contract labor individuals and for people that were still in the recovery phase of the staff and COVID, we had to have other staff pick up additional shifts, change their scheduling from, say, day shift and night shift from week to weekend. And we provided bonus payments, bonus shift payments, which is part of our general structure. But normally it's when people pick up an additional shift that they weren't scheduled for. But when people change their shifts, we allowed for these payments. And what's the real positive thing about this is when COVID hit the facility, the registry company, as they've done with everyone in healthcare and certainly in California and even in Plumas County, that they started wanting to increase their hourly rate, although we had them under contract. And so we were able to, by doing this with our internal staff, we were able to keep from having to alter our contract significantly. So on a go-forward basis, we'd be paying that higher rate. We did adjust the CNA rate by $5 an hour, but they wanted much, much more. And on the RN side, we really can't even get RNs, even if we paid the amount that they're asking for, which was approximately 100% increase on their contracted and previous rate. So we're able to address this with internal staff, and that led to the overages that we'll see come back off in the month of February. And the final piece of it was the board approved payment for myself for January. The professional fees, others, I know you all will be talking about that a little bit in closed session, but there are two cases that are incurring unbudgeted expenditures in that area. And the rest pretty much fell in line with budget. So overall, we had a negative variance of $42,000. These negative variances on net patient revenue and operating expenses were slightly offset by a positive variance in tax revenue. We received $293,000 versus a budget amount of $255,000 for $38,000. And I know that Plumas County as a whole has received additional tax revenues. It's not anything to not a game changer, but there's additional money out there, which is always a good thing. We did have a $10,000 donation, just general donation, that created that positive variance there. So bottom line is we had a net loss for the month of $169,000 versus a budgeted loss of $90,000. Are there any questions or comments about the mechanics of January's income statement?
Steve, this is Jerry. I don't have a question about the mechanics necessarily, and I think this is perhaps a question more for Sean. I'm wondering about our what we're doing regarding our skilled. Are we looking at bringing in new residents, perhaps once they've been, folks have been vaccinated, or how we're approaching that?
Yeah, we have.
Hey, Sean, just before you speak up, could I just make a comment about that? Would that be all right?
Yes.
I was in long-term today for a couple hours visiting my patients. And also I have a couple of patients who are interested in coming into long-term. And I can guarantee you that they are still hesitant to be admitted because of the virus things. It's really a handicap. And Ashley told me she is actively trying to recruit and get patients to come in. That's all I want to say.
Yeah. And I can go off of that. That is true. We are actively accepting residents. We do have a process where we quarantine for 14 days prior to them coming into the overall residential area. We have that, but there's still a little lingering nervousness out there about coming into skilled nursing, even though our numbers are down considerably, but we are actively interviewing and accepting residents into the skilled nursing.
So is there an opportunity? I'm just wondering if there may be less hesitant if they've already had their vaccination, the folks coming in. And I'm wondering if there's some opportunity for us to maybe, partner with county health so that we can offer it to maybe a prospective resident so that they can get, if they aren't already, so they can get their vaccine and then feel comfortable coming in. I just wanted to bring that up as a question.
Well, I know that our residents are vaccinated. Is that right, Casey? I know Stephanie's not on. I believe our residents are vaccinated, but if what you're saying is if we can offer that as part of the transfer, if they haven't already have it, if we can offer it up.
Exactly. That's what I'm asking.
Yeah.
This is Stephanie. I can speak to that because it is actually something that CDPH is talking about for recommendations for new admits. Our residents have received their first dose of vaccine, so they haven't had their full increments and they're due for that in another 2 weeks. But CDPH is recommending that all SNF facilities partner with their SNF pharmacy. So ours is Omnicare, about getting their first dose for vaccines prior to admission through the SNF pharmacy. So we're working on that with Omnicare. Most of the residents in our area and almost all counties 75 and older have already been vaccinated. So hopefully if we are looking at prospective residents, they have already received their vaccine.
Yeah, and there's something else, Jerry. When I say that the patients are hesitant, families are also hesitant, and it isn't that the patient's going to get the virus, it's just that they are now isolated from their families. And believe me, I'm getting requests from family members saying, oh, so-and-so needs to be on antidepressant because they're so depressed. And these people are in a very small facility. They can't have visitors, they can't go outside, and families don't want to put their loved ones in that situation.
Yeah, okay.
We do have a new, there is an AFL out currently from CDPH that is offering, we are open for visitations. It is limited, it is by appointment only. It's one family member at a time. We have the ability for the outside visitations on the patio and inside visitations to where the resident family member that's coming would receive an antigen swab prior to admission. So we would know their COVID status prior to coming in. And that letter is going out to family members today or tomorrow.
We have the Dawn and the assistant Dawn over at the skilled nursing facility have already initiated with Stephanie a workflow to practice that, to provide for residents visitation. We've already got that in place. So we're taking the AFL, we're putting some process around it, both inside and on a nice weather day, outside. So we are starting to activate that to try to get that psychosocial piece back, moving forward again, and try to get out of the COVID cloud a bit. And I think that will also help with some recruitment.
I'm not quite sure who to address this to, but kind of a mechanical question. How do you verify someone coming in that they've actually received their vaccine?
The card.
This is Stephanie. I can answer to that. Any vaccine that is given within the state of California is required to be registered with the California Immunization Registry within 24 hours of admission of the vaccine. So we have the ability to look up the patient's information in their registry. And everyone does receive a vaccination record card when they go to a clinic, but we usually can verify through the immunization registry.
Yeah, I have that vaccination card myself, and I was just wondering, gosh, what happens if I ever lose it?
Take a picture.
Yeah.
With your phone.
Yeah. We've got it in a registry, Ken, somewhere for you.
All right. Well, thank you. I
No,
feel better.
We know who you are. We know where you are.
All right. So
One question, why are we quarantined for 14 days? I thought that went away a while ago. I thought they reduced the number of days for quarantine.
No, for new admits coming into skilled nursing facilities, that's the current CDC and CDPH guidelines that we still have to follow.
okay. Steve, we're in the financial report and we got off onto this. Anything to follow?
The only thing I would say to that, unless there's not any more questions of the board, the only thing I would say to follow up with that discussion is that our financial position, our balance sheet remains strong, and will get stronger over the next, over the remainder of our fiscal year. When I reported to Jerry Nielsen about the supplemental payment we'll receive from the IGT we made in December of $292,000, I gave a number of 600, just under 700,000. We've received confirmation that there was a direct grant also in that program, and will now be receiving a total of $936,000, equal amount from each of our two Medi-Cal managed care organizations, $468,000, and we've already received the first payment last week from one of the payers, and so we'll be receiving another $468,000. We should be receiving our cost report settlement for fiscal 2020. The as filed amount was just over $1.4 million, and they'll also adjust our rates to the as-filed cost report through the current fiscal year. So our financial position remains strong, and I think that we can continue to not make the bulk of our decisions or the priority of our decisions off of finances in the short term, but looking towards the long term, and also continuing to keep our staff and patients and residents safe, as we've done very, very effectively. So I guess that's the report.
Well, then one other thing that we discussed at the treasurer's meeting, and that's the increase in days in AR. And I don't know if you want to talk about it now or when we get into HRG.
Yeah, unless, you know, I think it's best if we talk about it under HRG.
Thank you for letting us know about the upcoming funds too, Steve. That's definitely makes me feel a little better.
Virgin.
Yeah, it makes us all feel better.
Thank you, Steve. I guess I'm looking for a motion to accept the financial report.
So moved.
All right. Second, please.
I'll second.
Kristen seconds. Okay, Dr. Walls.
Aye.
Thank you. Rich
Aye.
and Kristen,
Aye.
Jerry,
Aye.
and I will vote aye. Thank you, Steve. Okay, so we have on this agenda item number 9, board meeting status. Question is whether we want to hold board meetings in person starting in March, assuming that we remain in the red tier or better. I think I'd made a previous request here on our agenda items like this. If we could have a notation about future agenda items, at least who will speak to these things. I'm assuming this is you, Sean, but I'm not sure of that.
Yeah, it was just, I wanted to put it in front of the board and, if you will, get the temperature of everybody. I know that as we go into red tier and hopefully orange coming up, you know, as we remain diligent. I was just going to query the board to see if you wanted to try to get back, obviously, with the 25% piece associated with this, but getting back together, still having the Zoom to the public and to those that don't need to be in the room, but being able to report more in bunk. It's a query to the board to see where we want to go with this since we're moving down tiers.
Steve, let me make sure I understood what you said. You're trying to hold it within the guidelines for 25% capacity and just have board members and necessary staff in the room?
Right, and you know, if we choose to go with some public chairs, they will of course be meeting all guidelines and just holding it to 25%. But once again, I just wanted to put it out there to query to find out if this is something that we would like to, if you will, sneak back into or move back into as our tier structure changes in the county.
Questions, comments?
Just Dr. Walls, I would certainly be in favor of that.
Me too.
Can we consider this in, I guess, an addendum to this that says something like, well, it's already stated here that we remain in the red tier or better, and we can change our mind down the road if we should approve this during today's meeting?
Do we have to make a formal vote and everything on this? Can't somebody just decide?
I prefer to leave it up to the president to decide.
Okay.
I think that makes sense. And then that way, you know, if it needs to go back or whatever, it's easier for that to happen.
Okay. My biggest concern is that we have adequate distancing with wherever we meet. So one of the things maybe to consider, Sean, is depending on the number of people who may want to participate, that alternative sites for meetings also.
So we could talk about that. I was at a Chester Fire Board meeting, and they had a lot of space in there. So just we'll consider it. You know, as long as you want me to look into it, or Stephanie and I to look into it, you know, and coming back together, we'll make sure that we adhere to the compliance requirements.
Okay, look into it. I'd like to just consult with you and confer with you prior to our next meeting, see where we want to go with it.
I'll work with you then. Thank you.
Thank you. Okay, this is the added item number 10, the Seneca Healthcare District rebranding logo change. I looked at the logo and I'm hoping other ones, or the, logo change, hoping others had a chance to look at it as well. Again, assuming Sean, you're going to speak to this?
Yep, we're gonna tag team. I think Chelsea's on as well. So part of our journey, and we are definitely on a journey here at Seneca, is to take a look at updating some of our marketing materials and our branding. And we've taken a look at, I'll just hold it up. Our badge, the biggest indicator on our badges and our branding is SHD. And I don't think really anybody understands what that is. It's very manufacturing looking. It's SHD. I don't know what SHD is, and folks that don't know, that aren't local, do not know what SHD is. In fact, some locals don't know what SHD is. And where the Seneca Healthcare District is a really small and sort of blended into a 1980s pastel color of the purples and greens. So Chelsea and I, we stuck our heads together, and Chelsea, you can jump in here anytime, to say that we would like to have something that's a little more pronounced, something that really speaks to Seneca, and something that, quite frankly, is cleaner lines and a little more updated. So we sent Chelsea out, and she brought this back to me within a couple of hours. And Chelsea, if you want to go with it, you can kind of give them the background behind this, but I'm going to be looking for approval to change our branding. Go ahead, Chelsea.
Yeah, so the idea with this logo is to just kind of clean things up, and as we rebrand, as we're moving forward and we're letting the community know that there's new and exciting things happening at Seneca Healthcare District, we have a fresh logo that will go with many different types of marketing materials. It's easy to apply to different backgrounds, things like that. So it's just a nice clean logo that we can hopefully, make work with any forms of advertising.
It's
I
hard
have
to,
just one question for you, and just want your thoughts on it. When I look at this, I think it looks nice, Seneca Healthcare District. But if I was not familiar with Seneca, I wouldn't know where that is. And so my question really is, perhaps in small print underneath somewhere or something, it says something like serving the Lake Almanor Basin or something, to give people a sense of where we're at. Oh, Seneca, that's in my area.
I would argue that if you put Lake Almanor Basin, no one would know where that is either, which is good. So it's
Well, Dr. Walls would know that we've had the previous board discussions about whether we should keep the Seneca name, because it really doesn't mean anything. It doesn't identify, where we are.
I was on that. I listened to that board meeting. That was a couple of years ago, I believe.
Right.
And I believe it was extremely. There were spirited conversations around a name change.
Controversial, yes.
That's the word I was looking for, controversial. And where Seneca's been around a long time, when we were thinking about the rebrand, we did talk about renaming, and I brought back that old board meeting to mind, and I thought, wow, that might be a bridge too far. So we just went with the rebranding. So I just want to put it out there that rebranding is going to be very important to us for a lot of reasons. But I wanted to bring it to the board for consideration and perhaps a vote, or bringing it back to the board. Honestly, the sooner the quicker, if we can pull this together, because we're planning some fairly large community things coming up in the spring, and in the next couple of months we have town halls coming up, and we would like to be able to, if you will, do a reveal. But once again, if the board doesn't feel this is baked, we'll go back and we'll work on it some more. But this is at least the starting point, if not the finish line, if we get approval.
Personally, I really like it. And sorry, Chelsea, I just wanted to say, I really like this logo. I think it's very nice. And as you said, very clean. And I think, to Rich's point of renaming, we did talk about it. I kind of feel like maybe we spend our time and energy somewhere else rather than on renaming it. I think this goes a long way into providing a different look and showing that we're moving in a different direction. That's my personal take.
I agree with
And-
you. I really like it. I think it's great. So good job. Nice job.
Okay, well, it sounds like there's, I think I'm hearing some consensus that we should move forward with this. To do so, we would need a motion to accept.
Ken,
Yeah.
I just wanted to ask Sean a question.
Sure.
Sean, do you remember when Bernie Poole had a sporting goods store in Chester?
Yes, I do.
His wife was Loretta Poole, and she was the director of nurses. And she was the one that first came up with a logo for Seneca Hospital. And on it, she drew some mountains and some pine trees. And it's kind of sentimental to see that it's still here today. That's all I wanted to say.
Thank you.
We have some mountains and pine trees, or one. We had a couple of pine trees in here. We actually had a bear, a deer, and a swan. But it got busy. We tried to put a lake and one of our nurses fishing on the lake, but that got too busy as well. Yeah, Dr. Walls, is the sentiment going to be? I understand the sentiment. I do. Is it going to be problematic if we push this forward without a community quorum, if you will?
Oh, I'm all in favor of this. I think it's real nice.
Oh, okay.
I don't think there's any, I
All right.
can't imagine that there'd be much fallout. But, I could be wrong.
Never
And you
know.
could- And if you want to change the name, you can always do that at a later date.
Yes,
All right.
I'll make a motion to approve.
Jerry's, okay.
I'll second.
Kristen seconds. So Dr. Walls, your vote?
Aye.
Okay, and Rich?
Aye.
Okay. Jerry? Oh, I'm
Aye.
sorry. And Kristen?
Aye.
And I'll vote aye. So
Hey, thank you. We're going to start actively moving it immediately. Chelsea, we're on the go. Thank you.
thank you. Thank you both. Nice work. Okay, let's go to the information only items. The HRG report, Steve?
Yes. So Tabby, the standard report, as Rich mentioned, so for January 2021, the air days went from 67.6 to 75.5, which is a complete failure of the revenue cycle and completely unacceptable. It's different from prior months where really the contributing factor on the variance from our target, or even getting us within the target range, was the over 90 days. For the month of
I'm getting a little bit of feedback from somebody with an open mic. If we could ask you to please mute your microphone if you're not speaking. Steve?
Yep. Okay. So the under 90 days, or 0 to 90 days, also is in excess of targets. So it was just a very, very poor month. Pursuant to this, we had a meeting with our leadership team from HRG, and we said that we appreciate the analysis they're doing, but the analysis seems to only be telling us what are the components of the AR that's presented here. In other words, that there's this much in the over 90 days, there's this much in this payer category, this and that. Still not getting down to root cause, and absolutely not addressing an action plan that we would then measure ourselves against the progress in the subsequent month. So they put together a pretty on-the-fly response to that, and it's a start, but it's inadequate. So, as you all know, we have a weekly revenue cycle call with the leadership team from HRG, and then also our revenue cycle group at the hospital. And what we decided to do was this week we canceled the call, and for the next couple of weeks we canceled the call with the larger group, but we met with myself and our revenue cycle coordinator, Sarah Lynn, and the HRG team. And we had an extremely frank discussion with them about things that we then decided after the meeting that we would keep the larger group out of the discussions for now, so we could speak openly and try and break through some of the barriers of our inability to bring the AR days down. Subsequent to this, our revenue cycle coordinator here at Seneca raised some concerns about some things where she had directed HRG to do things, and the HRG had represented that they had been done the way that they were requested to be done, and it was proven they weren't, and ultimately it led to an admission on the part of the HRG staff that no, they didn't do it, and they misrepresented what happened. So we then again met with her bosses, and they will be bringing on a new supervisor on our account based upon the fact that we feel that the trust has been damaged irreparably, and that we're not seeing the relationship and the performance from that relationship. And so we'll be bringing on a new individual. We will be using the current individual as a transitionary thing. So that's good, because usually it's somebody quits, somebody gets fired, and then we're left holding the ball and trying to bring a new person up to speed without that assistance. So we're hoping that that will help. In the month of January, they missed all of their targets. We did miss the unbilled target. We're just slightly above it. So it instead of the penalties being 2%, they were only 1%. But because we had a fluctuation of 20% in our revenue, that AR days measure did not trigger. And this is something that I'm going to have to look at if we continue with them as our billing outsource vendor. We're going to remove that fluctuation from the penalties thing, because it's silly. They're coming nowhere close to meeting their targets, and then being able to avoid the consequences of that because of this fluctuation in revenue, which I'm still not convinced that it's a direct impact, but there is some impact there. It's just the way our contract reads. So when we look to evaluate our continued relationship, that's something we'll take out. So they were penalized for 4 targets, so just over $4,000 in penalties. We're sitting here at February talking about January. We look at having 6 months to transition away if we want to go to another vendor or even consider another vendor. So I think we'll be looking at the month of April's performance and our May board meeting to determine whether or not this is something we want to continue to try and salvage, or we want to put this out for a bidding process and look at an alternative solution. Questions?
I have a question, Steve. It's I appreciate all that detail. It's not specific to that, but thank you to you and your team for going to that level of trying to get this squared away. I guess my question actually has to do with the self-pay piece.
Right.
Because as I look at this, it looks like we have, according to them at least, the majority of the self-pay are either in total delinquency or total final notices. And I guess my question is twofold. First, how are we communicating, or are we as a facility communicating with these folks, or is it just HRG? That'd be my first question.
Well, the answer to that is twofold. First is all of the communications to get to the S4, S5 notice level is done solely by HRG. When it goes to beyond the S5, the collection notice, it comes back to us, and what we're currently having to do right now is the revenue cycle coordinator I mentioned is having to look at every single account that's being referred to for collection to ensure that we really have been sending out statements and that the patient just has not responded. So kind of a tag team, and it's a burdensome process that doesn't help us at all. And hiding behind the third-party AR days that we're challenged with is some challenges we have with getting out private pay statements and ensuring that those statements go out. But rest assured that when people get, if we actually do send them to collections after we review it internally and they call us to complain, we will do a review of it. And if we see that we can't clearly see that we have sent out statements and made attempts to contact them, we're willing to pull it back into active AR, but want the patient to make a commitment. Because quite regularly what we see when we look is, sent the statements, made the phone calls, either someone didn't answer or, hung up on them, whatever it might be. And this is a broad characterization, but I'm just saying that's what we experience a lot. People really do not respond until they go to hard collections. And sometimes they don't even respond in hard collections until they're trying to buy something on credit.
So at what point in the process do we look at the possibility of it being a charity expense or falling under that category?
Well, that's done all along the process. Mainly the way that works is that when the HRG representative calls to make collection efforts, when it's still in the active AR, not in the bad debt hard collect, is they attempt to collect the balance in full. Then the patient says, I can't pay that in full. And then we offer payment plans, and we're being a little bit flexible on that, where we'll take up to 12 months where we only wanted to do, depending on the balance, we had a tiered structure, 3 months for smaller balances, 6 months on larger balances. But we're flexible now, and if people say they can't pay that, then they're offered to submit a charity application, and that part is done through our office.
Okay, thank you. And I guess the last part of my question about this is, I'm not quite sure how to ask this, but if someone comes in and they're self-pay, is the amount that they are charged the same as what one of the insurance companies would pay for the same service? Or are they charged more?
Yeah, without question. We have one charge master. Everyone receives the same gross charge. It's what a person is responsible for is where the difference starts. And this is kind of where healthcare is really messed up, is that people that don't have insurance, that are most likely the ones that can't afford to pay a medical bill, don't receive a negotiated discount that all of us get through our insurance company. And so we certainly put forth a 20% discount offer to patients, as we do to anyone that has a patient responsibility, where it's primary or secondary or whatever. But then we also work with them with the charity care. And the way we like to think about it is we don't ask anybody to pay something they really can't afford.
Appreciate that. Thank you, Steve.
Yeah, Jerry, are you asking, just for clarity, are you asking that if a person wants to pay cash, they want to pay with a credit card at the time of visit, that we have the ability to create a cash pay CDM where it's discounted for, this has been done before, obviously, where being where we have the ability to provide a cash number to somebody at the time of the visit and they want to do the whole thing, they have the thing right there. Are you asking for us to be able to think about or provide a cash charge description master and versus our standards charge description master?
I guess I'm just asking whether we might consider it, since we are a community facility, and I don't know if it makes sense. You know, I think Steve would probably be the one that would most know whether something like that could make sense, but I'm just looking at these numbers too, and I'm thinking, well, you know, if there's a way for us to be able to do something along those lines, then perhaps we wouldn't have all this outstanding, and maybe we'd be doing a better service for the community. That's I just brought it up as an idea, something to think about.
Certainly. Actually, Steve and I have had just, not in long conversations about this, but, discussion around this a little bit, but we can certainly keep that discussion going.
We do offer a cash discount, don't we?
We do. And what we have to be really careful about is we have to charge everyone the same gross charge, because Medi-Cal and Medicare will have a big issue with us if we make a gross charge to someone that's less than what we're charging a federal or state program or a federally supported program. So the way we do it again is that we charge everyone the same gross amount, and then that we just reduce the balance down by a cash discount or whatever you want to call it, the same way that we reduce down a third-party payers to the contracted rate that we've accepted. And we have freedom to take as big of a discount as we want on that, because once it becomes a patient responsibility, then Medicare, Medi-Cal, those guys, they say, you guys are on your own. The relationship is between you and the patient at that point. What we don't want to do is we don't want to create a standard where then patients that have insurance and then have a responsibility after their insurance pays, that we then have to discount that, say 50% as opposed to 20%. And then we lose that because that patient has theoretically and most likely the ability to pay it. So again, it all comes down to what is the patient's ability to make the payment. And if they say, I can't make it, we say, do a charity application. We'll look at it, and we're reasonable, and we do offer charity, and we do provide charity. So I think we're doing it. Maybe we just don't promote it very well.
Steve, I would suggest that there are some alternative funds floating around out there. I don't know how useful they'd be, but example, mental health departments have MHSA funds, Mental Health Services Act funds, and the adage with that funding stream is for their clients, whatever it takes approach, they can pay. It's very flexible funding. They can pay for a lot of things as long as it's related, medical bills, housing costs, if they can just relate it back to the person's need as being mentally ill. Victim witness funds are out there to pay for medical bills. So there's some, I guess, additional potential funding streams. I don't know how, significant that would be, but they're out there.
No, that's very true. And we try and look for that, the Victims of Crime Fund. And then also if someone is uninsured, has private pay, has uninsured, and they say they can't pay their bill, then we try and steer them towards applying for Medi-Cal. And in some cases, we'll do what's called presumptive eligibility, where Medi-Cal approves them in advance. And then we have a certain period of time to do the formal application. So again, maybe we're not promoting it as well as we could, but it also falls upon the patient to work with us to get this stuff done.
Sure. Just something to keep in mind. Thanks.
Yeah, we want to find any third-party payer we can. Individuals a payer of last resort always.
Okay. Anything else for Steve on the HRG report? Well, thank you, Steve.
Hey, Ken, I have one more thing real quick. Is one of the other things that we are working with HRG on is in response to the community surveys and even our employee surveys. We're very close to launching a patient satisfaction survey So when a individual is contacted by HRG by phone, they'll have to be given the opportunity to do a survey, a short survey at the end of the call. The last thing we're working on is that we want to provide to the patient and the community someone to speak to at HRG if they have a direct complaint, if they're not just going to say, yeah, I'm going to tell you guys aren't doing that well, but I really would like to speak to someone about the problems I'm having. And so that is something that will provide a direct contact at HRG when people have significant issues, some of which were brought up in both the community employee survey. So hopefully when we meet next month, we'll be able to tell you that's live.
Okay. Anything else?
That's it for me.
I just had a quick follow-up, Steve, if you don't mind.
Okay. ahead.
So, well, I appreciate that we'll have a direct link for HRG for them to speak with. I'm assuming / hoping that we'll be following on that and making sure that they do take care of it, right?
They're supposed to, yeah, they said that they would provide like logs. They'll provide us the results of their survey, and then they'll provide us logs of calls they're receiving so that we'll be aware of the patients that are raising complaints. Yes.
Okay, so we can make sure that their problems are addressed. Thank you.
Mm-hmm.
Okay. That moves us on to the committee updates. Item number 12, Strategic Planning Committee. And I believe we just decided we're going to carry this over until our next meeting for a little more in-depth discussion. Am I correct about that, Sean?
I have some updates for the board, but as far as the committee itself, forming the committee, I'd like to carry that forward. But I'd like to give some updates to the board. So I want to do existing facilities upgrade. We ran through this last board meeting, but I want to give some updates. So some of the things that we're looking at in 2021 and their status, just quickly. Our new hospital roof is, I told you, is OSHPD approved. We're approved for that, and it's going to bid. We had an old bid, but we're going to go back to bid because we only had one bidder that responded. So we're working with our architects and Linda McCurdy to move it to bid again. And hopefully we'll have more than one. And as soon as we get and select, we'll move on that. So a new hospital roof. Hospital.
Sean, can I ask you something quickly there? What is the OSHPD approval process? I mean, I don't have any idea what they're looking at. Are the materials, or is this? I don't understand what they look for.
It's anytime that you disrupt, and Linda, you can jump on this if you're on the board meeting. Anytime that you're disrupting the skin or any piece of an OSHPD 1 building, you have got to get approval through OSHPD. It's just a stepping stone. They want to make sure, and I'm not going to speak to this very eloquently, so I apologize. The roof is considered by our architects as an OSHPD 1 program. So OSHPD had to give approval to the program, to the plans, and they have to bless it before we can move on it. Okay. But that has been done.
Okay, thank you.
Okay. Existing hospitals. So we're putting out another bid. We are going to paint. We are going to do a different paint schema along with our roof. So we're going to give the old hospital a new face, some new colors, fresh coat of paint along with the CT building, every outbuilding, and the clinic. The clinic hasn't been painted in some time. It's chipping, it's looking bad, and I don't want to see a lot of wood rot. So we are going to bid on all of that for 2021. That's also in process. We are looking at new hospital flooring, and I know I've heard this, that we already have new hospital flooring, but it's brown, and frankly, it's difficult to see the cleanliness of it. So we have sort of mixed match. It's sort of a quilt of different types of flooring throughout the facility. So we're looking at standardizing on a facility flooring material that is more sterile looking, and it is better for patient care in the entire facility. So we're looking at that. Updating of the hospital inpatient rooms. They have wallpaper that's been put on. I don't even know when. It's been a long time ago. So looking at pulling the wallpaper off and just painting and just generally making them look better, a little more fresh, updated, the rooms. While we're going to be in this building for at least the next 5 to 6 years, let's at least give it a little bit of love. security cameras, we have received 3 proposals from security cameras. Now, this is not only partially a requirement, but it's been a staff request for some period of time. So we have looked at putting security cameras, which is the regulatory piece of it, over our medication dispensing units. So we have to have a camera that takes a look at those all the time. But in conjunction with that, we are also looking at putting external cameras, including night vision capabilities, out to all of our internal and all of our ingress and egress doors, so that we can see what activity is going on there. It's also going to help us with our certain COVID workflow right now, where people show up at the front door and ring the bell. We can actually see people approaching. And so that's gone to bid. We've got those 3. We're going to make a decision on that. The shore power we talked about is approved, and we're just waiting on the snow to melt a bit. The clinic waiting room, so the LAC, the Lake Elminter Clinic waiting room is getting a complete makeover. We call it the fishbowl, because it's surrounded by lots of windows, but we're going to do a mix match. We're going to make it look much better. And then there's the remodeling of the Reynolds house, which has already been planned, and that should commence really shortly. So that's existing facilities, things that we're going to be doing that are well in process at this point. Any questions before I move to new facility? No. Okay. In the last board meeting, I talked about bringing on our advocate, our person that helps guide the entire process from entitlements and CEQA all the way through to design, build, bid, build, and all the way through to population and first patient. We selected, I selected, I won't say we, it didn't really go to Building RX. This is a company that I have worked with at Sutter before years ago. They built big hospitals for Sutter, and this project manager, Donna Huntingdale, was literally responsible for keeping things on track and on budget the entire way. She's an engineer. She's also a project manager. So we had our kickoff just today, and she was able to gather information. She's pulling together our plan. They're going to have Gantt charts. We're going to have just a nice flow and methodology for this process through every single milestone until we actually populate with patients. So it was very good. We had some really good dialogue today. I'm glad that Donna's on board. So that's moving, and the selection committee will meet Donna and be able to ask her questions around flow, methodology, and such as we move forward. We are scheduling and conducting our Whipfly closeout session. Whipfly did our market study, our analysis, our numbers. So we're going to do the last part of their engagement was a closeout presentation. So they're scheduling that with Steve. And then we are engaging in the philanthropic side of our business as we start to build towards the hospital build fund. We're going to be engaging, well, we're engaging heavily in the community foundation where there's a vertical. I will be an active member in that as we look at ways to provide a tax sheltered entity for giving. So we're going to start our financial piece as well as we begin all this other stuff going on. We need to start looking at our financial options. And part of that, I think, is going to be through some philanthropy. So we just need to provide a vehicle for that. And that is the strategic planning update.
Questions, board?
Well, sounds great.
Plenty of stuff.
So Ken, you weren't going to appoint, you didn't want to appoint members to the committee today?
I thought Sean wanted to carry that over till next time. Am I correct?
We want to do it today. That's great. I'd love to know who's going to be joining us in the fund.
I think you can just do that, Ken, because it's not something that the board has to approve. It's just something that you, as the chair, can do.
Okay, I can entertain interest. How many members are we looking for here? I guess we can't have any more than 2, right? Right. Who has interest, expressed interest?
I'm still interested.
I'm interested.
Okay, so Rich and Jerry.
Great.
I'd like to I don't know where you're at with this, Sean, but understand better what the schedule is for that.
Yeah, the schedule actually is being developed right now. We are going to take so we're going to cast way out. You always kind of work a schedule backward. So we're going to cast our schedule out at 5 years, which if we get the wind at our back, and I heard a physician say today, hurricane wind at our back, we're going to go cast out at 5 years. And so we have our program manager that's going to do our 5-year back it up, and each milestone will have will be divided in a Gantt chart. So I hope to have that within a couple of weeks and be able to share it with the board next time.
Okay, well, that said, Rich, Jerry, consider yourselves appointed.
I will
Thanks,
include
Ken.
both of you on the calls.
Okay. So moving on then to item 13, your report, Sean.
Sure. So I always start with COVID. We are COVID-free. I'm very, very pleased with our community. We've done a really good job of knocking the curve, taking the curve down in the county. We are now red tier. We do occasionally still have community members, coming in with COVID-like symptoms. We have a very good process for that. So I'm pleased to say that we are full service open, including OR, and we are holding our own. Our focus has really been, and I want to throw great props out to our staff. Our focus has really been in vaccination. Stephanie and the team have been working diligently with the county. We've had now three successful vaccine clinics that it was like a Swiss watch. They just worked so well. So I want to give props to that team. That is a continued effort as we move through the tiers. Stephanie, do you want to say anything about this?
So we actually have had 4 community vaccine clinics, and we are projected to have one every week with at least 100 vaccines coming to our side of the county, and every week. So right now we got an allotment of 600 in Plumas County that will be showing up on Monday, and that's about our regular increment that we're going to be getting.
So
And as I understand that, I'm sorry, excuse me, people need to register through public health, and appointments are scheduled for them.
Yes, that is correct. So anybody that is interested in a vaccine, no matter what tier or age population we're currently vaccinating, can fill out the information portal website or call Plumas County directly on the COVID line to get on that list. Then what happens is they open up registration, and depending on the amount of vaccines we get, they fill those slots. Then I get the spreadsheet from the county with all the names, numbers, and birth dates, and away we go.
Okay, well, sounds great.
I also want to publicly acknowledge Chester Peninsula and West Almanor Fire. They have literally come out and just helped us immensely. So I just want to make sure that that's noted. They've been excellent. So there's a COVID update. Exciting. I would like to see us really, really doing well before our summer season hits. So as far as vaccinations. Mid-level recruitment, physician recruitment. So we did hire Medicus. We had the representative from Medicus actually come out and do a profile. This is an accurate profile of our area. This isn't, hey, we're Tahoe, come and visit us, come and work here. It was real. It was, we just talked about our community. We talked about what it looks like in all the seasons. So it was a very, very honest profile that they're taking out to take to in physician recruitment. Chelsea has been working with them as well as far as the marketing budget so that we have maximum distribution for these. So I'm expecting, I finished up the profile amendments today or yesterday and sent them out to them. So we are now actively in the hunt. So excited about that. I'm really hoping to pull some really good physician recruitment together. I am going to say that we are going to be working on a very good visit plan, so that rather than just an interview, it is going to be a series of interviews. It's going to be well, provided we stay red, it's going to be a COVID lunches, COVID dinners. I want them to meet board members and community members, and I want them to get out and understand our community versus just having an interview with myself and Dr. Walls or Dr. Cooper, anything like that. So I want it to be more of a welcoming sort of interview. Let them ask a million questions and see every single part of our community, what it's about. I think that it provides for a better understanding of what their lifestyle will look like. So we're going to be putting that together, Chelsea and I, but I'm pretty excited to get things moving in that. We do have Sonia Troxel will be starting in early April. Sonia is a physician's assistant with a cardiology expertise or background. She's excited. She is living here. She's moving actually up now. The family's been up here for a while. She starts in April. She will be accepting patients shortly after that. Very excited, great personality, really happy to have her on the team. So we've painted her office. It's going to be next to Dr. Cooper's. We painted it. We're supplying it with everything that you need. I understand she's bringing a couch into the waiting area this weekend, so that's great. So she's excited as well.
How many days a week will she be, Sean?
There'll be 3 initially. She's got young children, and as soon as she figures out the whole childcare thing and gets her cadence, it'll be 3 a week to start.
That's great. Okay.
Really excited for her. Been speaking with Dr. Bearcat, has reached back out to me. I met with him this week. He would like to start once again spinning up some of the ortho work that he has done in the past and perhaps have clinic again. And we're also working with Dr. Rice that actually Jerry introduced me to. He's a really great guy. And we're having conversations with Dr. Rice around orthopedics as well. I'm in conversation right now with a podiatrist that is interested in coming up. They have a home here and maybe doing some work here. I'm diligently working on a dermatologist. Not easy, but very hard to find. But they also have visited up here several times, this person from the Valley, and is curious. And I have a call in from an OB doctor that I have to return that would also like to consider clinic. So we've got some activity here. It's just a matter of titrating it, making sure that we have enough clinic time, clinic space, proper equipment and things to move forward. But the fact that there's interest is exciting. So we'll keep it moving.
So Sean, for Dr. Rice, I think, were you able to touch base with Sandy over at Banner?
I was.
Okay.
I did that right away. And Sandy loves the idea, but Sandy's, they are under contract with Banner, so I'm having to work through that contracted group.
Oh no, that's going to take forever.
Right.
All right. Well,
he doesn't work for Banner directly, so I have to work with a larger group.
gotcha.
Okay. But yes, so Sandy's aware, and she likes the collaboration though. So operations, let's move into operations. I have good news on the Chester Airport procedure. Yay. The FAA has approved it. The KTEX has been approved on the 29th of January. So it has met all criteria. It is waiting publishing. So the FAA will sit there and they'll publish it to all of the what the pilots use for looking at instrument approaches when they go into different facilities. If they take too long, they will issue what we call privately, so we can actually provide our Aerovac companies with a private published FAA approved procedure before it gets out in all the books and everything else, because that takes time. So we are a go. We are a go. We're just, I can't wait to do my first instrument approach into Chester.
Fantastic.
So Sean, please
Nice work.
just fill me in how that works just real quickly. So when we do have bad weather, we will be able to get somebody here. I mean, that's my question.
This is the next follow-up is going to be going out to all of our transport companies that do this and talk about what they call their Part 135.
Mm-hmm.
So they make an agreement what they can do with their aircraft with the FAA, and that's what they have to follow parameters. But frankly, this is an instrument approach procedure that literally allows them to descend in the clouds down to 247 feet above the field. So this is a really good procedure. And I can't imagine that at least our fixed wing aircraft they'd do this in a heartbeat. This is no big deal. We have to talk about the rotor wing because the rotor wing often has some less capacity as it relates to their instruments. So we have to talk to each one of our providers and talk about our instrument approach and see what they're willing to do.
Thank you.
But I think it's going to be great either way. Facility cleanup just quickly. It's underway. If you haven't come by here, we have a huge dumpster sitting outside the clinic that is full to the brim with our gunk. And we have plenty of gunk to go. So we're doing a round 2 where we go up and we identify stuff that is not viable, not usable, doesn't have any PHI associated with it, but we are doing our cleanup, and I'm really proud of everybody. Everyone's in cleanup mode. So I hope by spring we are looking, it's part of Project Botox, right? It's part of the whole, let's look better. I got to tell you, it's been great, but we filled one and we're going to fill another, I think, at least. So that's going very well. We did an internal staff survey. I talked about that. I spoke to it in the last board meeting. We received the information back. I can tell you that the results are going to be used. The findings are to educate and develop our improvement strategies, how we change and we upshift our culture. Where deficiencies have been noted, it has been shared with all of the managers. And we are going to be, we're going to take this as an opportunity to really take a look at how we function within the organization culturally, how we work together as a team around all these things that were identified. There's nothing here that is overwhelming or shocking at all to me. It's just now we know, now we understand where we need to work, and we are creating action plans to work in that direction. We're holding an all-staff series of 3 town halls on March 10th. We are doing 2, one at 7:30 in the morning. And Chelsea, help me out here. What was the second one? Is it in the evening at what time?
6 p.m. in the evening.
6 p.m. at the. Thank you. We're going to. Let's go to mute, Chelsea. Thank you. It's going to be at the Recreation Center. We are going to be following COVID guidelines. So it's only going to be 50. It takes 250, but we're going to go to 50 spaced out. I would like to invite the board of directors 2 at a time so that we don't have a brown problem. 2 at a time to reach out to Renee if you want to sign up for one of those times. So there's 2 on Wednesday in the morning and the evening, and then we're doing another one on Friday at 7:30 in the morning. This is an all hands on deck. And basically we're going to be talking about our journey forward, our path forward, the expectations, my expectations, the vision of how we recreate ourselves. And I'm very excited to share the vision with our staff. So we're going to be moving that forward. And of course, our physician staff are always welcome. So we work with Renee to get on one of those. Marketing and public relations, looks like we're going to be able to spin up community forums. I'm trying to work with Chelsea, and I'll let her speak in a minute with the chamber, where we have community forums allowing the public to it's a Q&A. Sometimes it's going to be a little bit, it's going to be a little, let's revisit some of the things we've done in the past, but I'm big about not driving in the rearview mirror. So let's get it all out and let's talk about it. Let's talk about the future. But I'm very excited about our community forums so that we can share our vision with the community as well and allow them to dialogue with us directly. So Chelsea, do you want to speak to that at all?
Sure. So the community forums essentially will be like a town hall, and it's something that Seneca Healthcare District, the Chamber, and then any other organizations that want to be invited can be part of. We're going to try and get something going consistently so that people can ask questions, they can stay updated. And so it'll just help with our marketing, our PR, and our connection with the community.
Right. And this is also going to be used, these forums will be used as we start to develop our strategic plan, as we start to actually shape our new facility. I think it'd be a good place to be able to share our updates to the community as well. And that is it. The rebranding effort was brought in as an agenda item, so I won't revisit that. And that is the CEO's report. Any questions?
Sean, I have a question. Have you reached out, I'm sure you already have, to the Hamilton Branch Fire Department about I think they're trying to get it on the tax roll this time for an increase in wages, or they may lose some services there. I have a neighbor that's on the board for them, and that there sounds like there's some issues there. I just hate to see losing that facility. I just think that also, as far as us, that's huge in the community for letting people know that that is really important, even if we do have to pay a little bit more in this area.
Yeah,
that we need their services to help aid the hospital also,
Right. I've been working with Renee on visiting different boards, and COVID has been a bit of an issue. Some of them are online, but I don't have a number, or it's not Zoomed. I have been trying to, if it's a physical, I've been showing up as often as I can. I certainly expect that my rhythm in these kinds of committees and board meetings will be much more as we've moved into the red tier. And I'm hoping that it's more public so that I can go and represent Seneca Hospital or Seneca Healthcare District there.
I know Hamilton branches are in person. I went to one a couple months ago, and they were in person because they really didn't have anybody there. So
Yeah.
I just think that that's really important. We can't lose their services, their emergency services. And
Right. Yeah, I will definitely represent Seneca Healthcare there. I'm also interested, obviously, in getting when the Elk starts spinning up, the auxiliary is going to be having their first face-to-face in March, and I've been invited to that. I'm pretty excited about that, so that we can revisit. So yeah, I'm really hoping the COVID cloud clears a little bit and we can do a little more FaceTime.
Other questions for Sean?
Any questions?
Well, thank you, Sean. Appreciate that. Move to item 14, which is our departmental reports. We had a compliance report submitted by Chelsea. And if you've had an opportunity to look at that and have questions, now would be the time to ask.
It all was very clear to me, and I appreciate the level of detail.
Yeah.
Ken, I have a question for her. Well, I guess I can ask her since I work here, but I just wanted to know if we could get a copy of the OIG exclusions checklist, because I'm not really that familiar with it.
We can follow up with her, Dr. Walls, about that. You know, and like I say, you do work here, but if you want us to run that down for you, let us know. Unless you want to do it.
Thank you.
Okay. So second report we have comes from, who's this coming from? Ann Holt. And this is on our telehealth contract with Renown. This looks like a nice little arrangement. Any questions about that?
I was just wondering if, like, what types of physicians that we're going to have privileged through Renown.
And do you want to speak to that, or do you want me to jump in there?
I can speak to it pretty quick. Right now, we have cardiology patients that we see. We don't have many cardiology patients that come here. With Renown themselves, they have increased the number of providers and the number of specialties that they have willing to see patients through cardiology. So they have a bunch of new pediatric patients or pediatric providers for oncology and some others. I can send out the list to you if you would like. I don't have it right in front of me. But, you know, we definitely have the ability to see most of the patients that Renown has in our area via telehealth, so we can help prevent some of their travel.
And will the Renown telehealth physicians only see patients that have gone to Renown, or will they see anyone?
So they will see anyone that's referred to them. What we've run into in the past is an issue of cherry picking, because we can't send all of our Medi-Cal patients to them. So we need to be very careful on who we're sending over state lines and making sure it's not like we're providing a different service to those patients. So as long as a patient is at this point in time established with a provider in Renown that does telehealth options and they live in our community, then we can help reduce that travel and see those patients. We're still trying to figure out how we can increase the help that we offer to the number of patients that we have. But we're really running into that cherry picking issue of, you know, sending select patient overs and not everybody over.
And so then we also, if I'm understanding correctly, if someone were to go to, say, you know, Chico or Reading for services, the Renown physician via telehealth would not be available to them. Is that right?
Right, because they would be taking on the care of the patient just like the specialist. So if we send them to Chico or Renown, then those are the providers that would be following up with them.
Okay, so if we have patients that go that other route, do we have a telehealth option for them?
We don't have contracts in place, but it's not out of the realm of possibility that we can't help them. It would be a conversation to make sure that we have a communicating platform. So the IT would be the main issue in that regard. but the technical version of can we house that patient here? Yes, we can. We just have to make the connection with the provider and make sure our IT is communicating with them.
Okay.
There was, Jerry, go ahead.
No, it's all right. Go ahead, Sean.
Well, telehealth, when it first started taking off, we had telehealth companies that were basically medical groups that were providing teleservices and then what they do is they would contract for big swaths, big areas, and they would provide teledermatology and lots of different stuff. That ran into, they basically went insolvent because, we didn't have a really good, at the time, fee structure. So that going away, I think that telemedicine is starting to rebuild itself a little bit more with that in mind about patient migration patterns and where they go. And if we have a third party kind of tele company that comes forward and facilitates that activity, regardless of the group, it's actually like a third party, then we'll be a lot better off. But right now, everyone's kind of doing their own thing. They're sort of spinning up their own stuff. So I'm not sure what Enlo's telehealth capabilities would be right now. I know UC Davis has started off strong and kind of died out a little bit, but this is something that from being rural, critical access hospital in a rural area, I'm very, very interested in the capabilities of telemedicine as it starts to remature. It kind of went through a dip and it's starting to mature itself again. So, and they've worked.
Yeah, that helps.
I'm
Because
sorry.
was that going? That helps me to understand that a little bit more. Because I feel strongly that there is a place for this here, and I think that we can be looking for solutions as they come available to try and help our folks out.
Yep.
Sean, you mentioned UC Davis. Does Sutter or anyone else in the Sacramento area offer services?
So it was interesting because Sutter and Adventist and several large organizations went with third party with the whole, let's offshore, let's take this off. So it's companies that are doing this, and that kind of fell apart. So I think once again, I know that Sutter's trying to reestablish. I know that Adventist Health is trying to reestablish a telehealth presence. They've all struggled. It's been a tough road for telehealth here over the last 4 or 5 years.
So Sean, I'm assuming that all of them are focused on rural needs. That's the whole point of telehealth.
It's, every single organization, every single large organization sees this as a feeder system. I don't want to really use it that way. What I'd like to, they all want the telehealth transference of the patient into their system.
Yeah.
That's the biggest reason they started it, was to get the numbers up. Some of it is population management, those that are really paying attention to population health. But frankly, what I want to use it for is for the things that can do initial diagnosis to treatment to clinic. We want to try to keep our work here, but telehealth is that thing that allows us to arms reach out for specialty care and do an assessment for what is next. What's the higher level of care needed or not? I don't want to, frankly, I'll be honest with you, I don't want to feed the monster. I want to feed the community, not the monster. So our telehealth relationships will be such that it benefits Seneca Healthcare and the community, and provides a higher level of care. There's going to be some offloading, but I want it to come back through telehealth as well. And that's not what the model looked like in the past.
I'm sorry, I was muted. Let me move on here. We're done with the telehealth conversation. Okay. I talked to TK before the meeting started, and she had really nothing of significance to report today, but she would take questions if someone has a question. All right. And then we did receive a report from Jim Kooyman, and I don't know if Jim's with us, but I wonder if there's any questions from board members about the HR report that he's submitted.
Jim, are you on? He's on vacation, right? Yeah, he's on vacation.
Okay, good enough. That said, we'll move away from the departmental reports and we'll go to items for next month's agenda. I'm assuming Renee captured the conversation we had earlier about things to be put on the agenda. Renee?
I think she's muted.
She didn't, I did, so. we'll work.
Okay. We're pretty good then. That said, let's look at the time here. Why don't we take 5 minutes, stretch, and let TK move us into closed session. So we're at 11:34, come back at 11:39. I'm sorry, 4:34, come back at 4, let's just say 4:30, and we'll move on. Okay,
Would I-
everyone. Thank you for your patience. The closed session has ended and we are now back into open session. I can report that there were no decisions made during the closed session. There's nothing to report on any actions taken. So that said, our next regular meeting will be on March 25th at 3 p.m. And we will determine if we are going to meet at the Lake Elmore Clinic or an alternative site where we can meet person to person, or if we're going to continue with Zoom. This is all dependent on COVID and whether we remain in the red tier or if by some unfortunate turn of events, we have more cases emerging. So we will call that in advance of the meeting and let people know about the location. So that's it. Again, March 25th, 3 o'clock. Thank you all for attending. Thanks to the board members for participating. Talk
Thank
to you
you.
next time.
Bye, guys.
Thank you.